Well, good morning, everybody, and thank you to the organizers for inviting me out here. I think the room will be slowly filling with time as people work through the line out there. First off, I'd like to direct everybody to my disclosure statement. I do have a certain financial stake in what I'm about to present. So first off, what is it we're trying to treat? And here we bring up the topic of retinal degenerations. This is the overarching area of interest for my team. And we can further break down retinal degenerations into two examples just to give you guys a flavor of what retinal degeneration entails. So the first example I'll give to you is Retinitis Pigmentosa. You may or may not have heard of this because it's rare. It is a hereditary condition, although there are many underlying mutations that cause it. In contrast, there's something called age-related macular degeneration. You may have heard of this because it's common and it's associated with aging. So this demographic of the boomer generation means that there are a lot of people developing AMD and some called an epidemic. So, but from there, there's a lot of differences that you could point out between these two conditions. So here I'm giving a flavor for the variety of manifestations of retinal degeneration as a group concept. So on the one hand, you have what the doctor sees. So when they look in the eye, do an ophthalmoscopic exam. In retinitis pigmentosa, as the name implies, there's a pigmented disruption of the retina that covers the periphery of the retina, and yet the macula, the central vision, is relatively spared until late in the disease. In contrast, dry macular degeneration, shown below that here, is basically the opposite in terms of showing a kind of light pigmentary changes in the macula with the periphery being spared. And then in terms of symptomology, you also see this kind of opposite effect in terms of what the patient sees. So RP starts with a tunnel vision or night blindness, progressing to tunnel vision, and eventually loss of the central vision as well. So it can give you complete blindness, whereas AMD starts right in the middle of the vision. It's very disruptive. But the silver lining is that the problem stops in the central vision and doesn't normally make you go completely blind. But the key point is that of all these various manifestations, the key thing is the loss of the photoreceptor neurons in the back of the retina, the rods and cones, and when these die, the patient's rendered blind, regardless of the underlying etiology. Now, how are you going to try to treat this? One possibility is cell replacement using a cell therapy, or another is neuroprotection. So we've settled on the neuroprotective strategy, and I just want to make that point early and often because it's easy to lose track of that. Here's the rationale for it. The rod photoreceptor is the one that expresses the mutation, whatever that mutation is, and those rods degenerate first. However, that is not seriously disabling because it mainly creates issues for night vision. Night vision problems can be cured by turning on a light, turning on your headlights, using a flashlight, etc. But the problem is it doesn't stop there, and then the cones start to degenerate, and they degenerate as kind of knock-on bystander effect, and these cones are critical to most visual functions in humans. And so our tagline is, if we can rescue the cones, we can have a big impact on this disease. But again, the question is, how do you do this? So here I'm just going to back up and give you an overview of our cell of interest. It's the retinal progenitor cell, where it fits in to the scheme of various cell types that could potentially be used. Here I'm contrasting multipotent, like ES cells, derived from the blastocyst, from a multipotent tissue-restricted progenitor from the developing retina. So this project, I started this 20 years ago at Children's Hospital of Orange County. And we focused right away on this RPC. even though it's fate restricted and not immortal. There's a number of great aspects to the cell: low immunogenicity, something we concentrated early on, and a lack of tumor potential, and so on. And of course, we focused on RP because of the severity of the disease, and the rarity actually gave it some advantages from a regulatory standpoint. Now, there was a lot of preliminary work in both rodents and larger animals that I've got to just skip over here, but I'll let you know that we did do that. So then, as part of the bench to bedside, we've had to start interacting with the FDA, and there's a whole series of interactions you have as you move down the translational pipeline into the clinic and through the clinic. This is the preclinical package, as we call it, that we submitted to the IND, just an overview, to the FDA to get the permission to undertake clinical trials. They're very interested in your CMC. That talks about your cell manufacturing and controls. And our cells were manufactured at UC Davis, so a shout out to them. There's, of course, very thorough toxicology studies that have to take place. We did a lot of that work at Charles Rivers, and we partnered with NCATS for the large animal work in pigs. We did, of course, proof of concept. We had some proof of concept, but we repeated it with the GMP product, both in our lab and in partnership with UC Santa Barbara. And finally, we had to develop a clinical protocol that was submitted both to the FDA and the IRB to get approval to start the trial. And this all went in at the tail end of 2014. Here's a quick overview of the CMC, just to point out that you can't use, well, you're going to have a tough time using just typical lab product if you want to go into the clinic. And generating a clinical product involves quite a bit of testing and a number of changes to your product to ensure safety in humans. Overview of the toxicology. I mean, one thing is you want to make sure your cells are safe. Here I show a normal karyotype. That's pretty important. Also, we look for tumorigenicity. Here you see the graft in a rodent eye. That's the graft of cells. So you can see we're placing them in the vitreous to get this neurotrophic effect. So we're putting the cells in the intended location in a rodent model to demonstrate that there's no local toxicity in these particular studies. And then down in the corner here you see the results of a biodistribution study that was negative for any cells leaving the eye, so we never detected a single cell in the periphery of the rodents following transplantation, and we checked over many months. Here's a look at the proof of concept in rat. We use the RCS rat that has a genetic problem and develops retinal degeneration. Here you see the intravitreal graft. So the cells go in as a single cell suspension, but they quickly adhere to each other and form these neurosphere-like entities that just sit there in the vitreous, and they can survive for an extended period. And while sitting there in the vitreous and not integrating with the host retina, they elaborate their factors that diffuse into the retina and have the neurotrophic effect on the photoreceptors directly or indirectly. Here you see a splayed out host retina from an RCS rat, and then we can take a look at the various quadrants of this retina with confocal microscopy, put together composite imagery at the level of photoreceptor elements that are labeled with red for rhodopsin and green for middle cone opsin. And here's a control. The degeneration means you just don't see much of anything because rods and cones are absent in this animal, whereas in the treated animal you see quite a few profiles of viable rods and cones, and that's the basic concept of what we're trying to achieve here. Of course, anatomical rescue is good, but you want to see some functional rescue associated with that. We looked at that in multiple ways. One is the head turning behavior, the optomotor response, And here we see a positive signal from the cell-treated animals as opposed to sham and untreated controls. That suggests greater spatial well, it's like visual acuity, but it's from a rodent, so they can't read the chart, so you monitor their head tracking. Okay, so down below we have the more definitive readout, and that's an ERG. So that's electroretinogram, kind of like an EEG for you brain people. What we see here again is that the sham and untreated controls have certain amplitude of B wave, and that the B wave is better preserved in animals that have been treated, and you see some indication of a suggestion, anyway, of a dose effect. So here's a quick view of what we're going to do in people, having done all this animal work. We've got our retinal progenitor cells. It's an allogeneic product. It's going into people with RP. We're going to do an intraocular injection. It's going to go into the vitreous cavity. This can be performed in an office setting under topical anesthesia, so very simple. And we're not using immunosuppression, even though these are allogeneic cells, and that's because of the low immunogenicity of this product. And again, we're looking for a neurotrophic effect. Okay, so you need a lot of funding for this kind of translational work. We had an early translational award from CIRM. That was followed by a disease team therapy development award. That started in 2012 and really pushed the project that I've described so far once it was in the formal preclinical phase. I told you about our partnership with NCATS, and then there was also a startup company, that's JSite, that we spun out of UCI, that initially licensed the IP back from the University of California system and is now a standalone entity in its own right. We've had numerous interactions with the FDA, culminating in an active IND in early 2015. The clinical trial used the cells that were manufactured at UCSD. They're stored up there at UCSD and then shipped down as needed. Prior to use in the patients, they're thawed out for a couple days in a special cell preparation facility that's in Groves Hall, which you see behind Dr. Yang and me right there in the background. And then from there, the cells are taken to the clinical sites. Initially, there were two sites, one at UC Irvine and the other at Retina Vitreous Associates up in LA. There's now a third site in Boston. Here's the initial dosing of patients seen from the hallway, so there's no HIPAA violation here. This is at RVA. So in terms of the patient population, there were two cohorts. The first cohort were the more severely affected, so those people are entered first for safety considerations. They started with vision that was hand motions, means that's the best they could do is see a waving hand. And then that extended, the other end of the range in that group was 2200, which you probably know is still legally blind. The second cohort was somewhat better vision. These people were from 2200 to 2063, but you need to appreciate that they had very, very restricted visual fields, so even the acuity itself does not give the full picture of how severely affected these people are. We enrolled the first patient pretty quickly in the image you see here. Eventually there were 4 different dose levels. We started with 500,000 cells and worked our way up to 3 million. We completed dosing in 2016, and a total of 28 patients were dosed, and all 28 completed the trial. We passed a number of interim DSMB safety reviews between doses, for instance, to get the approval to proceed to the next dose. The product was well tolerated. There were a number of adverse events recorded. These were typically associated with what you'd expect from an injection, such as conjunctival hemorrhage, transient eye pain and the like. There was one severe adverse event, but this was worked up and found deemed to be not related to the cells. There haven't been any issues that people were particularly concerned about, such as tumors, epiretinal membranes, or immune rejection. Okay, efficacy. Well, first I want to caution everybody this is a single-arm, open-label study. It was unmasked. That's what open-label means, and the data were specifically generated to inform the design of the next trial, the 2B trial, which does in fact look specifically at efficacy in a mass format. So we picked for our primary outcome measure best corrected visual acuity. Now we picked it because this is the gold standard in ophthalmology and it's very familiar to both the FDA and our clinical sites. But you need to appreciate this is an extremely high bar for a severe condition like RP, where although it's a slowly progressing disease, it is relentless and people just don't get better. So the idea that visual acuity might improve seems kind of out there. But on the other hand, we can hope to demonstrate a slowing of the rate of the degeneration, but remember this is a slowly progressing disease, losing about 1 letter of vision per year. Another point I'm going to give you is the data I'm about to show you includes all the patients in the trials. Remember, some of these people had hand motions, vision, or count fingers. That's not quantifiable in terms of Snellen acuity. So all those patients were scored as 0, regardless if they had any improvement. So here's the data. Here's the 4 different dose groups, and the treated eye is shown in the solid colored bars, and the fellow eye is in the more faintly colored bars. This is the lowest dose, and we progress to the highest dose. We see some indication of a possible treatment effect at all doses. Notice that it is positive across the range. And we see some indication here of a stronger effect in the higher dose. If you compare it to the control eye, that's 9 letters at 12 months, which is, well, we thought it was quite gratifying. So that's the first trial. The people who finished this trial were entered into an extension trial where they continue their follow-up, and they were given the option of getting the other eye dosed, and that was a very popular choice. In the meantime, we did get this RMAT designation from the FDA. This is a Regenerative Medicine Advanced Therapy designation indicating that they saw something of interest and were willing to grant that, so we'd have increased interaction with them, and so they helped us plan out our 2B trial. So phase 2B was designed based on FDA feedback, as well as getting, of course, the IRB approvals needed. We needed funding for this, which again came from CIRM, but also J-Site raised a matching amount of money to power this trial, and this is, of course, a controlled trial. Again, we're going with a primary endpoint of best corrected visual acuity at 12 months because of the favorable results we did see in the first trial. And this trial is actively enrolling at this time. Okay, so based on the idea that we can potentially achieve some neuroprotection and possibly some neural activity reactivation of the photoreceptors, this raises the issue of whether this is potentially applicable to other diseases, and I think the answer is yes, because this treatment was not specifically designed for retinitis pigmentosa. Retinitis pigmentosa was just the low-hanging fruit in terms of a disease worthy of treatment, crying out for treatment. There are a whole host of other rare dystrophies out there that might benefit from a neuroprotective strategy. In addition, there's many conditions that afflict the retina that could also benefit from neuroprotection, because there are not a lot of approved neuroprotective therapeutics out there and available, even though this concept has been around for quite some time. And that not only includes diseases involving loss of photoreceptors, but also loss of optic nerve or retinal ganglion cell injury, which is also quite common in conditions such as glaucoma and optic nerve trauma and so on. With that, I'd like to thank everybody involved. There's quite a large team at this point involved in a project of this type. First off, thank the people in the laboratory, particularly Jing Yang, who's been a great partner on this. That's her right in the middle here. Again, that's our stem cell center right behind us, the Bill Gross Hall at UC Irvine that was funded by CIRM and by the Gross family. And also below us is where one of our clinical sites is. That's the Gavin Herbert Eye Institute, where the ophthalmology faculty are located at UC Irvine across the parking lot from us. So a shout out to Barry Cooperman, chairman, and he was PI on the clinical side for the first trial, and Mittal Mehta is taking over the reins on the 2B trial. Also David Boyer up at RVA, and now Jeff Heyer for the 2B. He's in Boston. We have our low vision people. It's very important to assess the visual capabilities of these disabled patients, and that's harder than you might think, and so we're fortunate to have a low vision expert, Becky Kammer, on board. And of course there's corporate entities involved for data collection, that's Synteract, and a big shout out to our corporate people at JSite, Paul Bresky, the CEO, and Terry O'Neill, the COO, and our FDA consultant, Bonnie Mills. So thank you very much.
Thank you. That was a really nice talk. This session is now open for questions.
Thank you. So I have 3 quick questions. So first of all, do you have any evidence that transplanted cells integrate into the retinal network? The second question, how does the fundus of the treated patients look like, or how does it look like in the OCT scans? And the third one is, do you discriminate between the genotypes of the patients?
Okay, so we don't know if the cells integrate in humans, but in animals, and remember this is human into animals, so there's a caveat there, but in animals we did not see extensive integration. I'm not saying there's zero, but it's very low. So the main point is that this does not require integration. Now, if you position the cells under the retina, you can achieve integration, and that's a known fact, but that's a different way of working with the cells. So we're basically going down the path of not worrying about integration. Okay, second one was what?
Sorry, okay. How does the OCT and fundus images look like?
Fundus, of course, the OCT and the fundus view on these severely affected patients is severely affected. So just like ERG, we're not expecting a big readout based on that. One thing I want to say is, as an ophthalmologist, the cells are easily visualized in the vitreous, and so it's easy to confirm that most of the cells do not go into the retina because you can still see them there in the vitreous. So you can see that part, but the functional readout is the key thing here. So far the anatomy is not a big readout. I'll just say that if we went into earlier patients, and we're not doing that yet, and we looked for preservation, then I would expect to see the kinds of things you're referring to.
Yes, but my question was more like, is this hyperreflectivity or whatever you see you can readily see the cells in the vitreous, right? Is this stable over time?
It's stable, but it's not infinite. So what we see is that the cells persist for an extended period, and then eventually they go away. But of course, they can be redosed.
Yeah,
That's the beauty of it.
and the genotype?
Genotype. So genotype is not an enrollment criteria in this trial. Remember that the genes affect the rods. We're mainly trying to perk up the cones. But even in the case of the rods, we're doing a non-specific type of therapeutic. It's not targeted to the mutation. But nevertheless, we are testing the people for their genotype so we can do retrospective analysis to see if maybe in some cases genotype does have an impact on the likelihood of success.
Good morning. So I'm Elise Legac-de-Lansalu from Gyroscope Therapeutics. My first question is quite close to the other one. I was surprised with your surgical procedure and that you didn't go subretinally. So can you please tell us a little bit more about how you chose to go intravitreally and what did you do in preclinical phases to make this decision?
Well, that's a really long story. One thing I'll say is that I've been doing both intravitreal and subretinal over those 20 years, so I had a chance to compare the two. And it was my opinion as an ophthalmologist, looking at the scientific data, that the patients were more likely to benefit to some degree earlier in the course of development if we go the route of neuroprotection. And I think results are bearing that out. So it was really a kind of pragmatic decision to go in the vitreous. It doesn't mean the subretinal space doesn't have validity or that might not work. It just means that I think this goes a lot smoother, and it seems like it does, yeah.
And my second question is, how do you explain the function since the cells are not placed exactly
Right.
where we are expecting
Yeah.
them? Thank you.
Yeah, that's got a few layers to it as well. One thing is, I got to say that by putting the cells in the vitreous in an unmodified form to get this kind of result was surprising on two levels. One, it was surprising that these cells had a neurotrophic activity in their own right without putting in a gene, which is something we were working on at the time until we realized, wait a minute, these cells actually have a neurotrophic activity and we don't need to modify them. The other point is that how is it that vision returns? Remember, I was telling you that seemed like a very unlikely option, but voila, there it is. So that's harder to describe or to rationalize, and yet I think there is an emerging consensus, at least in some people in this field, that there are photoreceptors in the retina that cease functioning but haven't yet died. In other words, there's a progression from a functional photoreceptor to a sick photoreceptor to a dead photoreceptor. Dead photoreceptors aren't going to see anything, right? And the functional ones see okay already. It's the ones that are sick. It stands to reason that these cells, and it's known to be true, that these cells no longer support the cone outer segment structure that serves as basically an antenna to see the light. So the cell is still there, but the antenna is missing. So if these cells get a signal to re-elaborate this antenna, then they can start seeing, then you can start getting an improvement in vision. And some data like this has been documented in humans with RP using adaptive optics, and we look forward to the possibility of actually documenting this.
We have time for one more quick question.
Hi, very nice talk. I'm wondering, you mentioned that this treatment can be applicable beyond RP1. So what are your thoughts about applying this technique to the diseases that result from the autosomal recessive, for example, Usher syndrome, or from the haploinsufficiency of the allele? Thank you.
Well, Usher's I can answer, I can partially answer. So I was a little hesitant to get into Usher's because it's more complicated for you. Those who don't know, Usher's syndrome involves the combination of retinitis pigmentosa along with neural deafness. So it's a more severe condition. Yeah, that was a little bit intimidating, but some Usher's patients got in line and were treated, irrespective of the underlying condition. So you should realize that Usher's also has multiple genetic defects. So there's probably more than one Usher's, so to speak. But I can say anecdotally that at least one of those patients that I'm familiar with had a dramatic effect. So based on that N of 1, I think it's possible that we could treat Usher's, and we've certainly not discriminated against Usher's going forward based on that. Thank you.